you. So, as I've just said, the agenda today is a little bit about who we are as a Momenta and as the provider of this service, identifying patients who benefit most from this programme and how to make medication adjustments safely. We will also at the end briefly go through the referral form as well and how to find this referral form within your clinical system. So just briefly to touch upon who we are. So you may have been fully aware of this program, but in case you're not, this program obviously has been running for a while now with the previous provider as Aviva. So since February this year, the transition happened, and now all patients referred since February are in our care as Momenta. So in terms of the program, we do have some really great outcomes coming out of this program. So we use a total diet replacement approach as part of a 12-month support package that we offer to all patients on this program. Weight loss is very heavily associated with going into remission, which is the overall goal for this program. So we do see really strong positive results of around 11 to 13% weight loss at 3 months, and this is maintained most importantly at the end of the program as well. There are lots of benefits to this program, both for patient and practice, but the main things to be aware of is that this program is free, so there's no cost to the patient to be on the program. So all of the products and equipment that they require once they start the program with us are provided. Practices also can claim some money back as well for referring eligible patients, so you can be part of the enhanced weight management service as well. So if you require information on that, let us know. We can send across the spec for how to claim and the SNOMED code used. Next slide, please. So as I mentioned, this program does have a strong outcome around weight loss, and this is achieved by what we call the total diet replacement phase, or TDR. This program does use soups, shakes and porridges for a 12-week period, and then it's slightly reduced in the phase 2 where people will come off these products and introduce a meal at a time. Being on the total diet replacement, products are nutritionally complete for all patients, so there are no additional supplements that they need whilst on this program, but the program itself will have a low calorie, so patients will have around 800 to 900 calories a day. So there's significant weight loss that's achieved in the first part of the program especially, and that is why when Ellen goes through the different medications and how to review these, this is why some of those medications may need adjusted whilst on the program. Next slide, I'll hand over.
Thanks, Rebecca. That's super, particularly this concept of total diet replacement, because I do see some GPs concerned that people might be at risk of vitamin and mineral deficiencies, which they won't be because it's 100% complete, as Rebecca was saying. So I'm going to be talking about referral, who does best on this sort of program, and support you a bit with the medication adjustments. So to start with, who do we encourage referral of and who does best? So we have the exclusion criteria, but I thought we could go into a bit more detail around potentially more of a positive focus on who we experience doing better on this sort of program, because there are now a number of ways to lose weight, but we find that those who are really well motivated and ready to make changes are obviously those who stick with the total diet replacement and the behaviour change program that follows that. And actually, I wanted to mention about people who are preparing for surgery, chemotherapy, or big life events. Although active cancer is an exclusion criteria, if people get a diagnosis in the middle of the program, or it's in your view a minor diagnosis of a cancer, we're talking about small squamous cell cancer, things like that, then it's not necessarily a no-go area, because this is a time of life for people when they may be very motivated to make changes and lose weight. And we know, of course, that if you lose weight, your anaesthetic risk is less, surgery outcomes can be better, chemotherapy can be better tolerated, for example. So that is an area where we can discuss and isn't an automatic no. And surgery, for example, people are nil by mouth and can take their products in during surgical while they're in hospital. Another area we get a lot of questions around is eating disorders. So an active eating disorder is an exclusion criteria, but I guess as a plea from us is to think about undiagnosed eating disorders. And I know as a GP this is a really difficult area for us, because we're very aware that really the NHS doesn't provide sufficient services and support for people with eating disorders, particularly binge eating disorders. But we do find that for some people who haven't discussed their binge eating with their GP, we can sometimes see that this is unveiled with using total diet replacement, and then those patients patients come back to you needing more support. So in some ways, to save you the work later on down the line, it may be worth with some people exploring whether actually they do have an eating disorder. The other area, similar area, is people with complex current mental health issues. It can be challenging to support them during this phase. So simple issues like depression are not a problem at all. But I think we have to remember that the people who deliver this program, although they're supervised by myself and highly trained, they are health coaches who don't have experience with significant mental illness. And again, it can be quite challenging to do a total diet replacement program. And if that slight stressor can unravel things for people who are going through difficult times, again, that's likely to come back to you to try and find them more support. So it's just to think about whether this sort of program is going to be suitable for somebody. Another area that we've become more aware of is inflammatory bowel disease, or people with multiple food intolerances. It's not a complete exclusion, but it probably is worth considering whether or not they're going to do well on total diet replacement. In our experience, some people have found that inflammatory bowel disease, for example, has flared up when using total diet replacement. So it may be worth talking through with somebody who has frequent exacerbations whether actually this is the right thing for them to do. And the same with multiple food intolerances, it can make it difficult for them to find products that they are comfortable with. But again, to some degree we can support people with that, but it can make it harder for them to complete the total diet replacement phase. An area I'm probably most concerned about is biliary disease. So active liver disease is an exclusion, but that's a bit vague, isn't it, when we're with our patients? I think it's worth knowing that rapid weight loss, certainly through total diet replacement, has been associated with an increased chance of biliary disease, because it promotes sludging up of the gallbladder if it's not regularly stimulated with regular larger meals. And actually we have seen some serious outcomes. So biliary disease, I think we can sometimes think is maybe not so serious, but we can see things like cholecystitis and perforation. So it's worth properly consenting a patient who may have had a history of gallstones, still has a gallbladder, to look out for symptoms. And of interest, ursodeoxycholic acid has been shown to reduce the chance of gallstones in those who rapidly lose weight. And you may want to talk to your local upper GI team about that if somebody's really desperate to do the program but has gallstones. A word about ladies in their fertile years. I think many of our patients with obesity have assumed that they're infertile or have had problems with fertility, and it's worth making sure they understand that this is reversed through weight loss. And we've had a number of unwanted and unexpected pregnancies following the weight loss. So it is, again, worth talking about whether they might need contraception if they're not already using it. An area that I'm particularly keep my eye out for is people who may have been misdiagnosed with type 2 diabetes. So it's worth being very sure that your patient does have type 2 diabetes and perhaps not misdiagnosed as late onset type 1 diabetes, or even insulin insufficiency that tends to go hand in hand with pancreatic insufficiency. So obviously those who are insulin insufficient will need to be on and some sort of anti-hypoglycemic agent. It is not safe for them to come off them. And we would pick that up usually by seeing rising blood sugar levels despite rapid weight loss. So we are aware of that, and there have been a couple of people who've been referred who were later found not to have type 2 diabetes. And then lastly, the people we see who do really well on this sort of program are those who are really well supported by their GP team. So thank you so much for your hard work. We know it's very difficult times at the moment in primary care, but we do really benefit from your support around making sure people are on the right meds and the right people are referred. So thank you for your hard work. So talking about medication adjustments next, I think my main message is be confident. I think we've had so many pills, taught to us and drilled into us that our patients need, but actually this program is very effective, and we can see that the blood sugar lowering effect of total diet replacement is very quick, and often within a day or two we see blood sugar levels normalizing. Blood pressure tends to drop a bit later, and this is data from the counterbalance study, and similar data was seen coming out of the direct study. So it may take 2 to 4 weeks or more for blood pressure to come down as weight is lost. So we will guide you, but ultimately you decide. You're the expert. You know your patient and why they might have been started on medications and how much you think they may engage with this sort of program. So when it comes to deprescribing glucose medications, remember, drops fast and can be from day one of the total diet replacement. So we advise that patients stop their medications or adjust them on the first day of total diet replacement, but not before. Otherwise, you'll be bothered by people getting anxious about very high blood sugar levels, potentially, if they stop too early. So if people are on 1 or 2 glucose medicines, our guidance is to stop all of those medicines. If they're on greater than 3, we advise continuing metformin only. So there's some discussion about, do we really have to stop metformin? And I think the guidance originally came out of the pilots who were looking to monitor for drug-free remission. So of course, if somebody remains on metformin, they don't officially achieve diabetes remission. So again, be guided by you and your patient. If it doesn't matter to them that they achieve drug-free remission, then it's okay. It is safe to stay on metformin. Of course, there are multiple other benefits around weight loss, cardiovascular risk reduction, even cancer risk reduction. And if somebody's happy on it, then it is safe to carry on and be guided by yourself and your patient's decisions. And the patients can also carry on gliptins or glitazones, but gliclazide and the glifosins are not safe with total diet replacement and need to be stopped. And for the glifosins, it's the worry about ketoacidosis, and of course, gliclazides, it's the worry about hypoglycemia. The GLP-1 appetite suppressants can be stopped if you want, if you have local cost pressures or there's problems with supply, which I know is quite widespread. But I do feel it's quite mean for our patients if we have suppressed their appetite and we release that suppression and it rebounds just at the point where they're having to restrict their diet. And they are safe. So if, again, you and your patient decide that you want to carry on with it, that is okay. If, again, if they're not too bothered about their whole drug-free remission. So in summary, what's safe, what isn't with total diet replacement? Metformin is. Obviously, gliclazide and the other sulfonylureas are not, because of the risks of hypoglycemia. The odropaglinide, which hardly anybody uses anymore, is not safe. Pioglitazones are safe. Gliptins are safe. The glifosins are not, because of the risk of ketoacidosis. The GLP-1 agents are safe. Acarbose is, but again, is rarely used now. Insulin definitely is not. So this is not a program for people who are insulin dependent or have been on insulin. So when thinking about glucose lowering agents, a nice flowchart here is if they're on nothing, then please still complete the forms for us so that we know what medications they are on, even if you don't need to adjust anything. If they're on 1 or 2, you stop the medications at the start of the total diet replacement. And it's very useful if you can talk people through what things to look out for if their blood sugar goes too high. So blurred vision, thirst, peeing frequently, infections, and so on. If they're on more than 3, you stop 2 and they stay on metformin or another first-line agent that they were on. And again, we just ask you to counsel them about what to look out for. Insulin is the exclusion. And remember, they mustn't stop until they've actually started on the day of starting the total diet replacement. Occasionally, we'll have to get back in touch with you because the blood sugar levels have risen too high and the weight loss has not been as expected. So we will get in touch with you if the blood sugar is over 15 or if the average blood sugar at 6 or 12 months has risen. And at that point, you can decide with the patient whether or not you want to add back medicines. Metformin we'd suggest would go back first, and then the other medicines that are safe in total diet replacement. Please don't add in any of the ones that aren't. And clearly, if you think they need insulin, then they unfortunately need to stop the program and get other forms of support to lose weight. So when we're thinking about adjusting blood pressure lowering agents, again, be brave. If the blood pressure is raised, then we don't need to change medicines. But if it's in range, then we need to stop one or reduce one medicine again on the first day of starting the total diet replacements. When we're considering which blood pressure medication to adjust, if there are multiple ones, then we need to consider what is the indication. We see a lot of people on, for example, propranolol for anxiety or migraines, tamsulosin for benign prostatic hypertrophy, and so on. So we need to stop the agent that's purely prescribed for blood pressure first, that would have been added last according to the NICE guidance. So that would be the spironolactones or alpha blockers or beta blockers, then the calcium channels or thiazides, so your indapamide and so on, and then your ramiprils or your losartans and things like that. But if they're taking the agents which affect blood pressure, but all are being used for other indications, then reduce the dose of one or more agent in discussion with the patient. And that can be difficult, but again, patients will be monitoring their blood pressure and we can get back in touch with you if they're experiencing dizziness or hypotension. So nice flow chart for blood pressure lowering agents. If blood pressure is not well controlled, then no changes. Helps to talk to them about symptoms of postural hypotension, dizziness, particularly when they stand up, and how to get support. Please, even if you don't make any changes, let us know what their medications are. But if they do need to change, if it's in range, identify pills specifically for managing blood pressure, stop the last added according to NICE, let us know what you've done, tell them don't change anything until day 1. So in summary, some medicines need to be adjusted due to changes in body weight or dietary intake, or because they're associated with weight gain. Some may be prescribed or administered by other services or settings, so don't forget to think about those. And it's about your clinical judgment. So you need to just ask yourself, if somebody lost weight or had major dietary change, is the dose of this medication likely to need adjustment? We advise, you decide, so you make the decisions ultimately on what needs to be adjusted. But if you feel it can't be done safely, or you can't get the right advice, you're uncertain, then the patient is probably not suitable for this total diet replacement program. So just a note on other medicines, this list isn't exhaustive because we haven't had enough work done in this area, because we've never properly been able to support people at scale to lose significant weight. So certainly we have no hard answers about this, but these are the medications that I believe we should be thinking about. Warfarin, for example, just probably needs more frequent INR testing, because as we all know that warfarin is affected by our dietary quality and by our weight. The DOACs need consideration. There are specific weight thresholds for adjustments depending on which DOAC you use. Digoxin again may need more frequent monitoring of levels and discussion with the patient about what side effects to look out for. Same with phenytoin and cyclosporin. Long-term antibiotics, again, we need to think about the weight-based dosing. Same with antifungals, a bit rarer for our patients to be on those. A note about beta blockers, they're commonly prescribed, and we do run into problems with propranolol, because that does seem to be commonly prescribed, particularly for anxiety and migraine, and it can exacerbate symptoms of fatigue and has potential for causing hypoglycemia and of course hypotension. Lithium is another one we have seen quite commonly, and we have seen a couple of participants run into trouble with toxicity, so it's worth suggesting more frequent monitoring of lithium levels and running through the side effects and of toxicity symptoms, so that patients know what to look out for. So I hope that was helpful. Very happy to answer questions after Rebecca, who's now going to take over and talk to you about referral.
Great, thank you. Next slide, please. Thank you. So this programme, there is no right or wrong way to refer into the programme, but we do have 500 funded places for the area, and we have no caps currently on how those 500 places are going to be spread across the area. So until you hear from us, please do refer as many people as you can. So thinking about how your practice can get involved, there are different ways that we can support you. So if we use the middle out of the 3 options, which is the usual care. So this is when people particularly are being diagnosed. We've seen some of the data come out from the pilot that people who are recently diagnosed do very significantly well in this program. There's usually quite a high motivation to not go on to any medications and actually go onto this program. Annual review appointments, or patients also coming in for requests to discuss their options around their diabetes and weight management. So this is the ad hoc approach, which is absolutely fine. And what we would encourage is that if there is anyone, as well as these people that you're working with, because the patients will be given the choice of a digital or in-person model, is to discuss with any other patients you think might be interested in this programme, so that we can offer more in-person programme all around Mid and South Essex. The 2 other options are the most common way to be more efficient with your time, because we're really aware that the time taken to identify people and refer them can be a little bit higher than other services. So there is a search that is available, which will help identify your eligible population. And there is also the pop-up which works, which will identify people as they come in for their reviews. So searches typically will identify around 10% of your diabetes population that are eligible for the service. It could be a little bit lower or higher depending on your numbers coming through and how many of those are the recently diagnosed people. We can run, after you've run an event, we can also support with bespoke events to support your practice at either a practice or a PCN level. And we have found quite significant positive results from doing it this way. So in other areas, we've run searches and we've invited anywhere between 30 and 70 participants to come to the session, where they'll have a talk around the programme from someone from a mentor, which will also be something that we would encourage staff to listen into, so that if people have got questions, you've got some information around how the programme works and the benefits for the people who take part. So we can support with what that discussion looks like, and then we would ask that the referrals are then taken place after the session or perhaps in the following week, with people booking in for their appointments to discuss the medications and any changes that they will make on the programme. Doing the search to identify patients and make a plan depending on how many you have that are eligible. We also recommend sending out SMS messages depending on what your system uses, so that patients can actually have a bit of an informed decision prior to coming in for an appointment. So we have a really great patient website. We have patient videos and animations which will explain the programme and what the programme will aim to achieve with them. If you are interested in getting some support from us around running an event, again, like I say, we've had some really successful events that we've run. So we do have some guides on what this looks like. So we can send that across to you following this session as well. And Debbie will be the person that you can link in with around setting something up, whether that's a virtual event or an in-person event with our support. I'm just going to share my screen now. So just to briefly touch upon the referral form for this service. So as I said, it does come up in the pop-up, which you may have already been used to, or you can download this referral form as you're working with someone. If you haven't seen this before, it's fairly lengthy referral form, but most of the referral form is actually auto-populated. So there's only one small section which would require you to manually add in the information. So the referral form will have all the information in terms of how to get in touch with our team. So whether you have a clinical question or want us to review someone before you actually refer them, please do let us know. You can contact our NHS inbox. The patient information will all pull through. So all the boxes in grey will be things that pull through from your clinical system. So it will just be a case of checking that everything's pulled through that you would expect to see. There is some information on here highlighting areas where we do see some referrals come through, which unfortunately would mean that they're not eligible for this service. So in the yellow and red, you'll see reminders around the upper age limit of 65. We must have a diagnosis within the last 6 years. And one of the most common reasons we have for an exclusion is we have people who their HbA1c is not in range as per this programme specification. So we must have a value within the last 12 months, and depending on if they are on medication or not on medication, the information, as a reminder, is all on the referral form for you. But as I say, all this information will pull through for you. Full reminder of the eligibility, inclusion and exclusion criteria is also on the referral form. So if you're not too sure, please do refer to this before referring the patient over to ourselves. There's a lovely flowchart here, which covers a lot of what Dr. Fallows has gone through today around how to make the decision around which medications to stop for this person on the programme. So if you're not too sure, then please do use this. But again, if you're still not sure, please do email us and we can support with advice around what we would expect to see for your participants. So the last part of the referral form is the most important part in making sure that we have no delays for getting the person onto the programme. And this is the section that will be manual because it will be based on the individual you're referring. So section A is double checking which medications is the person on, and that a confirmation has happened that the patient is also aware of any changes that you'll be making, or clarification that there's no changes to be made. This is the most common area that we find will delay and slow down the person starting on the programme. So if at any point we have a conversation and the person you've referred is really unsure about changing medications or staying on, we will place them on hold until we can have a conversation with yourselves to be ensured that we've got the right information. So please do make sure that they are aware. So the section to fill in is section B, which will have a table and all the medication that can be listed in here along with the action. And as we've said a few times, it's to be stopped on the first day that they start the products with us, and this will be confirmed and communicated by ourselves as well. So this is a drop down that you can go into on your system. So again, we've highlighted the areas where we would expect you to stop the medications because they won't be able to stay on these throughout the program, and the action column as well to let us know. And you can also let us know that you would like them to continue on that. This table is what we would advise is also sent to the participant or something in writing so that they've got a hard copy of it following the conversation, because phone calls typically could end up being a few weeks after, and then people do forget what the conversation was. An addition we've recently added is underneath the medication table, you'll see all the medications that this person is on as well. So if you're not too sure which they're on, rather than going back out of the record and back into the referral form, it should also all populate here for you so you can review the medications that they are on. So once you've filled out this referral form, you'll send it across to our NHS inbox, and there is a SNOMED code as well there so that you can see who you have referred into the programme. Once they're referred to our team, we will process within 5 working days, and we will communicate to you if the referral has been accepted and they're eligible. If they're not eligible, we'll let you know the reason why. And if there's anything missing, so for example, we do see quite a lot of missing data diagnosis or HbA1c that's perhaps not pulled through, we will communicate with you to get that information before we contact the participants and get them onto the programme. Once they're on the programme with us, we will also communicate with you at different stages and the SNOMED codes to use. So as someone progresses through the programme, you will be aware of that information. So that is the end of our session. I appreciate it's a very quick lunchtime slot. So I just want to open up to any questions that you may have, especially for Dr. Fallows. Please feel free to put them in the chat or come off mute if you've got any questions. And if you don't, as I say, we'll send across everything. And if you want to ask anything in an email afterwards, we can pick that up within our team and with Dr. Fallows as well.